Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We are currently on our hematology oncology sessions. We will be running through a few questions with you guys to help you on your journey to a 250. So, which anatomical structure is most likely responsible for these urinary symptoms after radiation therapy in this patient? A 55-year-old man with localized prostate cancer is scheduled to undergo radiation therapy. The radiation oncologist discusses the treatment plan and the patient expresses concern about potential side effects. The physician explains that one of the common side effects of radiation therapy for prostate cancer is a gradual increase in urinary frequency and urgency, often accompanied by a sense of incomplete emptying of bladder. Which anatomical structure is most likely responsible for these urinary symptoms after radiation therapy in this patient? Bladder, prostate, urethra, seminal vesicles, or rectum? So the anatomical structure most likely responsible for this urinary symptom after radiation therapy is prostate. So localized prostate cancer and radiation therapy, for the prostate cancer, the radiation therapy is a common treatment modality for localized prostate cancer. The goal is to deliver targeted radiation to the prostate to eliminate the cancer cell. And the prostate surrounds the urethra, and radiation therapy can affect the prostate gland and its surrounding structures, and the common side effects include irritation and inflammation of the prostate and leading to urinary symptoms. So the specific urinary symptoms include increase in the urinary frequency. The irritation of prostate can result in an increased sensation of needing to urinate more frequently. The radiation-induced inflammation can lead to a sense of urgency, where the patient feels a strong and sudden need to urinate. Swelling or inflammation of the prostate may cause a feeling of incomplete emptying of the bladder. So other options like bladder. So while radiation can affect the bladder to some extent, the prostate is more likely to be the primary source of symptoms. Urethra passes through the prostate, and irritation of the prostate can impact urethral function. The seminal vesicles are adjacent to the prostate and may be affected by radiation, but they are not a primary contributor to urinary symptoms. The rectum is in close proximity to the prostate, and radiation therapy can cause rectal side effects, but these are more related to the bowel symptoms rather than the urinary symptoms. So let's solve one more question. So what is the primary purpose of the conditioning regimen in the context of allogenic hematopoietic stem cell transplantation? A 30-year-old woman with severe aplastic anemia is scheduled to undergo allogenic hematopoietic stem cell transplantation. Her human leukocyte antigen matched sibling has been identified as the donor. Prior to transplantation, the patient undergoes a conditioning regimen consisting of high-dose chemotherapy and total dose irradiation to eliminate the recipient's hematopoietic cells. What is the primary response of the conditioning regimen in the context of allogenic hematopoietic stem cell transplantation? To eradicate residual cancer cells, to stimulate the engraftment of donor cells, to prevent graft versus host disease, to enhance the function of the recipient's immune system, or to eliminate the risk of infection after transplantation. So the primary purpose of the conditioning regimen in allogenic hematopoietic stem cell transplantation is to eradicate residual cancer cells. The conditioning regimen serves multiple purposes, including creating space in the bone marrow for donor cells, suppressing the recipient's immune system to prevent rejection of the donor cells, and eliminating the residual cancer cells in cases of malignancy. The high-dose chemotherapy and total body irradiation in the conditioning regimen aim to eliminate the recipient's existing hematopoietic cells, including any residual cancer cells. Now, while the conditioning regimen does help create a space for the donor self-engraftment, the primary purpose is to eradicate malignant or abnormal cells rather than to stimulate the engraftment itself. The conditioning regimen contributes to the suppression of the recipient's immune system, which helps prevent the rejection of the donor cells. However, it does not specifically prevent the GVHD, which is managed through additional strategies. We have a separate video on GVHD too before this one. So the conditioning regimen suppresses the recipient's immune system, and its purpose is not to enhance the function of the recipient's immune system. The conditioning regimen, by suppressing the immune system, increases the risk of infections rather than eliminating the risk. So infections are a significant concern in the post-transplantation period. Now, talking about one more question. So what is the primary mechanism of action of this targeted chemotherapy? So 60-year-old woman with metastatic breast cancer positive for human epidermal growth factor receptor 2 undergoes targeted therapy. The treatment involves a monoclonal antibody that binds to HER2, inhibiting downstream signaling pathways and promoting antibody-dependent cellular toxicity. What is the primary mechanism of action of this targeted therapy? Inhibition of tyrosine kinase activity, blockade of hormone receptors, induction of apoptosis, enhancement of DNA repair mechanisms, or antibody-dependent cellular toxicity. So the primary mechanism is antibody-mediated antibody-dependent cellular cytotoxicity. So the targeted therapy for a HER2-positive breast cancer is a receptor. So HER2 is a receptor overexpressed in some breast cancer, contributing to tumor growth. The targeted therapy for HER2-positive breast cancer often involves monoclonal antibodies that specifically bind to HER2. That's why it is called as a targeted therapy. The monoclonal antibodies in this scenario, the treatment involves a monoclonal antibody that binds to HER2, and the binding of the monoclonal antibody to HER2 inhibits the downstream signaling pathways, interfering with the pro-growth signals. The primary mechanism described is antibody-dependent cellular cytotoxicity, which is a process where immune cells, such as natural killer cells, recognize the antibody-bound cancer cells and induce the cell lysis of those cancer cells. So a pretty much fantasizing sort of technology out there. So other mechanisms like option A, which is the inhibition of tyrosine kinase activity, is a mechanism associated with small molecule tyrosine kinase inhibitors rather than the monoclonal antibodies. The blockade of hormone receptors is the mechanism relevant in the hormone receptor positive breast cancer and is not directly related to the HER2 therapy. The induction of apoptosis, while inducing apoptosis is a general goal of cancer therapies, the primary mechanism described here is ADCC, and enhancement of DNA repair mechanisms is not a typical mechanism of action of HER2 targeted therapy. One more question. So what is the primary goal of using this combination chemotherapy in the treatment of NSCLC, non-small cell lung cancer? A 45-year-old man with non-small cell lung cancer, NSCLC, is undergoing combination chemotherapy with platinum-based agents and a third-generation cytotoxic drug. The platinum-based agent cross-links DNA strands, leading to DNA damage, while the third-generation cytotoxic drug disrupts the microtubule function during cell division. What is the primary goal of using this combination therapy in the treatment of NSCLC? Induction of apoptosis, inhibition of angiogenesis, suppression of tumor immune evasion, targeted mutation-specific therapy, synergistic cytotoxicity against the rapidly dividing cells. So the primary goal of using the combination therapy with platinum-based agents and a third-generation cytotoxic drug is synergistic cytotoxicity against rapidly dividing cells. The platinum-based agents such as cisplatin or carboplatin are known for their ability to cross-link the DNA strands, leading to the formation of intra-strand and inter-strand DNA crosslinks. Now, this interferes with the DNA replication and transcription, inducing the DNA damage and preventing the cell division. The third-generation cytotoxic drugs, the third-generation cytotoxic drugs often include microtubule targeting agents such as paclitaxel or docetaxel. Now, these drugs disrupt the microtubule function during the cell division, leading to mitotic arrest and apoptosis. The combination chemotherapy, so the combination of platinum-based agents and a third-generation cytotoxic drugs aims to achieve synergistic cytotoxicity against the rapidly dividing cancer cells. And the drugs target different phases of the cell cycle. The platinum-based agents primarily affect the S phase, where the DNA replication occurs, while a microtubule targeting agents disrupt the mitosis. So induction of apoptosis is a general goal of chemotherapy, but the specific mechanism described here is the disruption of the DNA replication and microtubule function. Inhibition of angiogenesis is a goal associated with anti-angiogenic therapies rather than our question stem. Suppression of tumor immune evasion, while some chemotherapy agents may influence the tumor microenvironment, the primary focus here is on cytotoxicity. The targeted mutation-specific therapy, this scenario involves the conventional chemotherapy rather than the targeted therapies focused on specific mutations. Now, the cancer therapy agents, okay, now this is how the targeted therapy works. So there are some drugs which just inhibit the nucleotide synthesis, like the methotrexate, 5-fluorouracil, the thiopurines or hydroxyureas. There are some which inhibits the DNA synthesis, like alkalizing agents, bleomycin, anthracyclines, and other drugs like etoposide. There are some drugs which directly inhibit the cellular division, and these are vinca alkaloids and taxanes. Now, there are some of the key chemotoxicities that are associated with the cancer therapy. So the cisplatin and carboplatin are ototoxic. Vincristine has peripheral neuropathy. Bleomycin busulfan has pulmonary fibrosis. Doxorubicin, dinarubicin causes dilated cardiomyopathy. Trastuzumab causes cardiotoxicity. Cisplatin, nephrotoxicity again. And cyclophosphamide, hemorrhagic cystitis. So there are some non-specific common toxicities of nearly all cytotoxic chemotherapies, which may include myelosuppression and GI toxicity and alopecia. Thank you for watching. Keep studying hard.